And you've probably seen, for many of you that have attended several sessions this week, you've probably seen this. I'll quickly recap that our mission at Migraine and Headache Australia is threefold, and it's to provide reliable information, to fund research into migraine and headache, and to advocate and support for people living with headache disease. And we've been quite active this year in developing a number of new medically reviewed articles. We've been actively involved in submissions for PBS listing and often calling out for you to submit your own experience to help with the PBAC, the committee or the council that review the listings to take into account your considerations. We've been active in the media and had several articles and coverage on Channel 9. We've done Shades for Migraine back in June, and we have an emphasis on committing to care, which is about supporting small actions that can help make a difference in our migraine condition. And I'm sure that we'll be talking about some of those today. And I'd like to thank our event sponsors. Without these supporters, we would not be able to reach nearly as many people. We've had hundreds of people on each of our webinars. And so we'd like to thank Hydrolite, Teva, Lilly, the Brain Foundation, Lundbeck, AbbVie, and Pfizer for your support. So you're in the right place if you have migraine or headache, if you're a partner, parent, or caregiver, if you'd like to connect with others like yourself, if you'd like to ask a question, and we have our support group as well, I should say, on Facebook. For those of you that use Facebook, you're more than welcome to look up Migraine and Headache Australia support group up and join that support group. So a little bit about me. For those of you that may not be familiar with me, I'll be taking the session today and running through a couple of highlights and then answering questions. I've had migraine for over 3 decades. I've had chronic migraine for 7.5, and have been through a lot of the struggles that that people have experienced here firsthand. I don't pretend to understand everyone's situation. Migraine is very individual and unique. But one thing that I have been able to, been fortunate enough to do is crawl out of chronic migraine. And since doing that, I've found back my zest for life, my energy, my enthusiasm, and have become and wanted to pay forward some of the support that I received when I was really struggling with migraine. I'd like to sort of pay forward to others. And so migraine has become a full-time passion and vocation for me. And so I've become a member of certain organizations such as the Coalition of Headache and Migraine Patients, the Global Patient Advocacy Coalition, the World Health Education Foundation. I'm a member of the International Headache Society. I'm the founder of the Migraine World Summit. And of course, I am the Director of Operations at Migraine and Headache Australia, and am heavily involved as well in the Brain Foundation. And I've also spoken out on media and try to improve the awareness and understanding of migraine in Australia as well as internationally. So let's get into some of the highlights from the week. Now, I know that there's a couple of slides here. They may be heavy with content. I'm not going to recap all of the different pieces because I'd love to get to the Q&A and answer any questions that you still have. So get your questions ready. But I will recap some of the key points from some of these talks. And so the first session that we had this week was new treatments and treatments coming soon from Dr. Michael Eller, which was a fantastic presentation, quite a technical presentation as well. So for those that have been attending Migraine Headache Awareness Week, you may have found that this sort of ticked your objective of getting a really in-depth and sophisticated presentation. Some people may have found it quite technical, and so we're happy to kind of explain in as plain a language as possible some of the treatments and some of what's coming as well here. So he spoke about the 4 CGRPs. So these are monoclonal antibodies. CGRP stands for calcitonin gene-related peptide, which is a bit of a mouthful, but it's suffice to say that these are peptides or small proteins that are released during the cascade of a migraine attack. And these drugs, in different ways, block that molecule from taking action and leading to a migraine attack. They're not a cure, but they are some of the most effective and safe treatments that have been developed specifically for migraine. In fact, they're the first medicine that has been developed specifically to prevent migraine, if you can believe that. We're in 2022, and these have only been around for a few years. And there's 4 different types, and it's worth trying a different type of CGRP if one is not effective for you. Similar to the triptans, if one triptan is not effective, it is still worth trying another to see if you can find one that works for you. And so he went into depth into each of those. You can see here the status of each of these. Not all of them are covered by the PBS, but Ajovy and Emgality is. Vyepti has been recommended by the PBS, which is excellent news, but it has not yet been listed. They're in discussions with the Department of Health and the Minister's Office for Health to get that through, and we'll be letting you know as soon as that happens. But that's not all. There's more treatments. There's Gepants and Ditans, which are treatments that many people probably have not even heard of, that are coming soon. And these have been the Gepants have been released in the US. And we are expecting to see that these will also arrive in Australia within the next sort of 1 to 3 years. It's hard to say with any greater accuracy. I know it's perhaps frustrating for people who really need another option or are looking for another treatment. But it just depends on so many different factors. It depends on the organization. It depends on the resource. It depends on the TGA, which approve drugs, and then it depends on as well on sort of coverage and listing and insurance and so on. So it's quite a complicated process that's probably beyond the scope for this discussion. But again, we will let you know as soon as they are available. And they are really exciting because Gepants are treatments. There's at least one type of Gepant that has been shown to be helpful not just for acute migraine, but for prevention as well, which is one of the first options we have as people living with migraine, where you can take the treatment as often as you like, and it actually works better the more you take it, as opposed to other treatments where we've been told about medication overuse, and we have to be careful about that. So there's a whole area here that's really exciting, and will make the treatment of migraine easier as well. And then there's another treatment with Ditans, which don't have the same contraindications that triptans do for those who have perhaps a history of heart disease or stroke. And so that's another really helpful option that'll be coming hopefully soon to Australia as well. And then Dr. Ella also spoke about other targets, other potential avenues for research that are currently being investigated that may also show promise and could eventually develop into treatments as well for migraine. So the future is bright. We should be really hopeful. If you've not found a great sort of solution today, it doesn't mean that you will not find one tomorrow. And certainly if you haven't, if you have chronic migraine, if you have migraine 6 to 8 times a month, you're really at the cusp of preventive treatment. And in fact, if you talk to your doctor or your neurologist about prevention, and you tell them actually how many days you're completely free of any type of headache or symptom of migraine, you should be able to qualify if you are seeking a preventive treatment. You should be able to qualify, because very often, even though you may only have a couple of migraine attacks a month, your symptoms last on other days, and that counts towards giving you access and eligibility for a lot of these preventive treatments. So that's something absolutely to bear in mind. In terms of aging with migraine, this was the second talk that we had from Dr. Catherine Spira. A lot of people remarked how lovely she was, and she was very open about her own experience with migraine herself and in her family with her kids. And so she spoke about migraine in a childhood, and how it affects children and can express slightly differently in children, and how there's also limitations in treatments that are available to children because they just simply haven't been studied, unfortunately. But there are sort of behavioral and lifestyle factors that can be very helpful for kids who are struggling with migraine at an early age. In adolescence, migraine changes again. It picks up, and for a lot of young women, young female teenagers, with the onset of menstruation, this can also start to appear in a more significant way. And it's where we start to see more females develop migraine versus males. And perhaps that's due to menstruation. but there's also a lot of other factors that can play a role. And I think, for those of us that have kids with migraine in the audience, it's a really important time to identify migraine and to set habits and routines, and also to give our children the chance to understand migraine. Because if we can address it now at this early age, if we can nip it in the bud, then it can change the trajectory of the health and well-being of our child for the rest of their lives. And if they learn things like cognitive behavioral therapy and stress resilience, and learn how to manage their condition, it gives them skills that they can take not just for migraine but also for other elements as well. So there's a real opportunity there with children. And I've heard a lot of pediatric migraine specialists talk about how rewarding it is to see that change in individuals. But most of us here are adults that are living with migraine. And even then, it's not too late to turn the corner and to find improvements or make small changes that can really help. And she spoke about hormonal changes that fluctuate throughout the life stages of a woman, and how how hormones are part of every woman's life, every healthy woman's life, let alone those that have migraine. But there are options for hormone balancing and hormonal replacement therapy, and addressing hormones so that they don't become a trigger. But men still have migraine. I'm a living and breathing example of that. And migraine is still present in men, and can be still present in both women and men into older age. And whilst for the population, it is true that migraine decreases in older age. After sort of 50s and onwards, it tends to sort of decrease. It isn't true for everyone. And in fact, if migraine has gotten better and you don't have to worry about it at all, then chances are you aren't here listening to this talk. In fact, this community is almost going to be certainly people that that promise hasn't been delivered for. And so that's why we're here today. But there are still options. Migraine can be managed into older age as well. And there are considerations that we need to take within medication safety, particularly as we develop other potential health issues as we get older. That's a consideration that we need to take into account as well. So then we learned about headache types from Dr. Jason Ray. He talked about several different types, New Delhi persistent headache being one of the first ones, which is a really tough headache condition, perhaps one that has the least robust evidence for finding treatments for. New Delhi persistent headache, for those of you that aren't familiar, is a type of headache that just sort of appears one day and just does not remit. It just stays with you. And it can be in the form of sort of like a tension headache, but it can also present as migraine. And it's really, really tricky. And sometimes it's set off by a virus or an infection. Other times it could be set off by physical accidents, such as a car crash or some other really stressful event that may be an emotional or a mental component to it. And it's really an area that needs a lot more research and support. And so people with New Delhi persistent headache are often going through a lot of different things to try and find a solution. And often the way that it's treated is depending on how the symptoms present. So if it's presenting like it's migraine, then migraine treatments are often used. If it's presenting like tension headache or another type of headache, then different approaches are taken to try and address that. And so that was spoken about during that talk. Cluster headache is perhaps one of the most severe forms of headache that is known to man. I remember seeing research actually that compared different types of pain, and being shot by a bullet was found to be actually less severe than cluster headache, the cluster headache condition, as well as childbirth in some of the surveys and research that was found. So it truly is an awful condition with excruciating pain. But fortunately, there are treatments for cluster headache. High flow oxygen with a certain type of flow rate, which is really important, can be effective for the majority of people that have cluster headache. It's tricky to be able to carry a small oxygen tank around, but having that at home, having access to oxygen. There's also certain types of treatments that may be used in migraine, such as a quick-acting triptan, so sumatriptan injection that can also be used. And there's also really exciting research into preventive treatments that may be helpful for migraine, including devices as well as potentially some of the CGRPs. So, some great news and options coming for cluster headache as well. Really worth saying across some of the latest research there. And I feel for anyone that has experienced cluster. It sounds really, really awful. Menstrual migraine. These are attacks that happen around menstruation each month for women, most commonly just before menstruation. These are more severe attacks, actually, than just your regular vanilla type migraine attacks. They're more likely to be unresponsive to acute treatments, and they can present a real challenge as well. We had Dr. Ray talk about these treatments and options for these treatments as well, as I mentioned previously, around hormonal replacement therapy, balancing hormones, doing things that can address it. Just because you have hormones doesn't mean that you can't do anything about hormones triggering your migraine attacks. And then vestibular migraine. So this is a type of migraine that may not sound as severe as the other types, but it can be really disabling for those people that have this dizziness and vertigo constantly around a migraine attack or in between migraine attacks. It can be really disruptive. It can be hard to concentrate and focus. And for those people that have had any type of chronic nausea with their migraine attacks, it's awful. It's really awful. So if you've been seasick, you kind of appreciate what severe nausea feels like. And it's similar for people with these issues with vestibular, with balance and dizziness. And so whilst there may not be as severe head pain, it's still disabling nonetheless. So that brings us to a talk that we had from Dr. Bronwyn Jenkins about the research findings on headache and migraine. And this was research that was done by the community, the Migraine Headache Australia community. And so I wanted to thank everyone who took part of this. We had over 600 people respond to this survey, many of whom had responded to the first survey that we conducted a year prior. And so it allowed us to kind of take the pulse of the community and how they were doing now versus over a year ago with the outset of COVID. And what we saw was that most people, about 45%, about half, hadn't changed. Just over a third had gotten worse, and about 20% had improved. We looked at some of the reasons why that was the case. And what we saw in those people who got worse was that anxiety, depression, sleep, exercise were all sort of factors in those individuals who got worse. And interestingly, in those people who got better, they actually found that they were getting, their sleep condition had improved. They were working from home and had a supportive environment. And it's easy to understand how that might be the case. If you're working from home and you don't have a dedicated office or a private space, but you're working from the bench and you've got kids running around, you're crouched over a laptop because you don't have a desk. Those are all things that you can see how that could exacerbate a migraine condition versus working in the office. So it was really a mixed bag in terms of what how people have gone since then. But it just speaks to the fact that how important addressing some of these issues are, if they are issues for you, that they can make a difference as well. We spoke about other advances as well. Dr. Jenkins highlighted some research from overseas about interesting new areas within migraine, and one of those was with nutrition and specific diets. And two diets that were highlighted were a diet that was higher in omega-3s, and this was actually probably one of the most robust recent studies available for a diet that could be helpful with migraine. Talking about diet, I'm sure this will come up in some of the questions later, but diet's a really tricky area. There's no single diet for migraine yet that's been proven to be helpful for absolutely every person. But generally what you can say is that the less processed food you have, the better. And that's probably the simplest way to think about it. It's not to say that you're not allowed to have any processed food. I don't think that's realistic. I think that, at birthdays, we should be able to enjoy cake for someone special to us. But it's knowing that that the more that we're able to sort of have a healthy diet, say Monday to Friday or Monday to Thursday, the better we're able to do. And certainly eating the foods that we know are good for the brain, such as omega-3s and fatty oils from fish. But you can also get those from nuts, and walnuts is one that stands out here, which actually looks like a brain, so it's helpful to remember, are great for the brain. And so those are things to bear in mind. We also spoke about the ketogenic diet that is showing some promise in some people with migraine. It is a very difficult diet to stick to, so something to bear in mind. And something to do as well under the supervision of either a nutritionist or your GP, because it's not sort of risk-free, and it was a diet that I had to stop actually due to an issue with my liver. We spoke about COVID and headache, and how this infection may also have a link to New Delhi persistent headache, and that there's a certain percentage of people that have had an extended headache after COVID. But the good news is that for the majority of people that responded, it wasn't a prolonged. We did not see prolonged results, but it can happen, and so it is something to be aware of. And then we spoke about some new treatments as well that was covered off, and highlighted the importance of understanding what medication overuse is, and how that can be addressed as well. And then the last slide, the last presentation that I'm going to highlight was from Francois Cadu, who is the founder of Migraine Buddy, which has something like 2 to 3 million registered downloads. It's a huge platform for people to track their condition, and he was really generous in sharing data that has not been released publicly yet about some of the performance of treatments that are available for migraine, and how they perform for people that are taking them and recording their attacks in the app. And so his diary is one that's used by a lot of people. What it found, perhaps not surprisingly, was that triptans were the most effective in terms of the treatments that are taken by users of his app. And he focused on Australian users, and that there were also sort of treatments that, other treatments that were used that weren't as effective, which are some of the first line treatments, such as ibuprofen, aspirin, and paracetamol, which fell behind the triptans. So perhaps no surprise there, but also good to see that sort of reassurance. If you're like me and you don't respond to the triptans after trying all 6 that are available in Australia, there are combinations of treatments and other options as well that can be explored. And one example is naproxen, which is a non-steroidal anti-inflammatory that has a little bit better results than just your plain old ibuprofen by itself. And that can be taken with, for example, an anti-nausea medication, which not only addresses nausea, but it's been shown to be helpful with pain, which is something that I didn't realize until recently. And one of the great things about anti-nausea medications is that you can take them as frequently as you like. There's no medication overuse associated with an anti-nausea medication. So an example of that is metoclopramide. So something to speak to with your pharmacist or your doctor if you are still looking for a solution that can help address the worst of your migraine within 2 hours. That's kind of the gold standard here. We spoke about medication and hospital utilization in Australia, and how around 40% of people have been to the emergency department for a migraine attack in Australia. And that number probably each year is around sort of 10 to 20%. Despite having such a high rate of hospitalization, the results of going to the hospital are actually quite poor. Sometimes we're treated as drug seekers when we go to the hospital. Other times we're waiting alongside other sick people in the hospital in the waiting room who are coming in with severe injuries or bleeding, and are triaged above us. And because we're not bleeding out or showing any significant signs of in the same way that someone who's sick or vomiting uncontrollably, we're sent to the back of the line, and we wait for all the urgent people, so-called urgent people, to be treated before us. So the hospital really is an awful place, according to of what a lot of people are recording in the diary on Migraine Buddy. And so we can speak about how perhaps to avoid the diary if that comes up in one of the questions later on. And then we spoke about weather and migraine. And this was a really interesting part of the talk. We had a lot of people who said, whether weather is a trigger for me, absolutely. But it's just so variable. And Francois called out a couple of different factors that play a role in weather, which was the humidity, I think it was, barometric pressure, definitely, the change in temperature, the storm and the seasonality as well, and there were several other factors, and UV. So these were all different things that can play a role, and some people might be really affected by lightning and having a lightning storm. Other people are affected by the pollen. Even pollution may be a factor for some people. So it's a really interesting area that needs more research, more attention, which I know that they're working on. But it affects different people differently, and sometimes it can affect you, and other times it may not. If you've had a good night's sleep, you've been eating well, you've been sort of active, or you've been exercising, and you're feeling really good, you can go out into a storm and you're absolutely fine. And other times, if you've had alcohol, you're sleep deprived, you're busy or stressed at work, you see the storm and bang, right into a migraine. So it really is one of those variable things, and that's why it's helpful to kind of track your condition and monitor and adjust accordingly. So that's the highlights. I've allowed half an hour for Q&A, which is right on time. I'm going to open up my screen here, and we'll open to questions. I would love to hear from you. I'd love to hear from you any questions or comments or thoughts. I've got Anik as well, who's pulled out a couple of questions, so we'll get started on that. But thank you for those of you who are able to attend multiple sessions. That's absolutely wonderful. If today's the first session that you're able to attend, that's great too. It's great to have you here, and it's certainly better than not being able to be here at all. And we will be sharing the recordings. We've been sharing the recordings in the emails that have been going out, but we'll also share the recordings afterwards as well. So to jump straight in, first question is about the CGRPs from Marion, who has said that her migraines seem to come on in spring. Can Emgality be used just for that time? So one thing I'll say just about what we're going to be covering off here is that I am a patient myself. Even though I work at Migraine and Headache Australia, I'm not a clinician. So anything I say will not should not be considered medical advice. It's more information, educational in nature. So I'll be talking sort of I guess generically about what I understand about how these things work. But it's always a good idea to speak to your healthcare professional, to your doctor, your neurologist, sometimes even the pharmacist, if appropriate, before changing anything regarding your migraine condition. But I'm very happy to answer any question to the best of my ability and to the extent that I can. So Marion's question, can Emgality just be used for that time? The short answer is yes. You can use these treatments for shorter periods of time, but it's not the way that they were designed to be used. They're kind of designed to be used to establish time to take effect. And some treatments, some CGRPs can take effect very quickly. I know that Vyepti, which is an infusion, can take effect within an hour and then start to help out. But a lot of the other CGRPs that are auto-injectors that are given monthly can take a couple of months to show full efficacy. So if you do it for a season, for 3 or 4 months, that's great. If you know that it builds up and it works for that time, then that's fantastic. What has been shown in some people, and this is early research, but if you come off a CGRP, particularly if you're chronic, if you come off the CGRP and then you realize you need to go back onto it, it sometimes does not have the same benefit that it initially had. So you may lose some of the benefit of reintroducing it after having a break. So that's something to bear in mind. But in theory, yes, it is possible to do that. It's not how the drugs were originally designed to be used, however. Robin asked a question about Emgality again, about whether it's used for chronic or episodic migraine. It has been indicated for chronic migraine to be eligible to use it on the PBS. That's not to say, however, that it may not help people with episodic migraine. Doctors will be cautious in talking about whether the CGRPs can be used in episodic migraine. It really depends on the level of, what level of episodic migraine you have. There's been research that's come out regarding high frequency episodic migraine, which are attacks that you're having. So 6 to 8 days is probably considered to be high frequency episodic. But again, this area gets really blurry when you talk about how many days in the month you're actually symptom free. I'd love to hear from you actually in the audience. How many days a month are you completely free of any type of headache or symptom related to migraine? Because I know when I was chronic, I probably had 0 days, even though I mainly have 5 or 6 migraine attacks, big attacks a month. There was 0 days in the month where I was completely free of migraine. And so if that's the case, certainly you would benefit from prevention with a CGRP. If you're high frequency episodic, what the research has shown is that you have more in common with chronic migraine than you do with low frequency episodic migraine. This is quite a new and developing area, and so a lot of headache specialists, particularly at the International Headache Society level, have become more aware of this. And there's actually discussion about, what are the implications? Do we start to make some of these treatments available for high frequency episodic migraine? And actually, that is starting to happen. So I guess the short answer is it depends on where you're at in episodic migraine, but certainly high frequency episodic migraine prevention should be considered. And it doesn't need to be medicinal prevention. You can think about addressing some of your own behavioral and lifestyle factors that may be playing a role, such as sleep, such as addressing depression and anxiety. We know that from the research that if you improve your sleep or you improve your depression, anxiety, just by improving those things, and which could be seeing a psychiatrist, or it could be just getting an extra hour, or improving some of your sleep hygiene, maybe avoiding reading your phone in bed, falling to sleep a little bit earlier, having a better routine. Those things help migraine. They help the brain and they help migraine. It's really interesting to see how that helps and improves. So that's definitely something to consider. One of the other questions is from Catherine, and it said one of the talks mentioned a tendency towards osteoporosis with CGRPs. What's the evidence for this, and should they be avoided in people with this condition? And we also had Aldith asked about that. That is a great question. I don't know the answer. I think you're going to need to speak to your doctor about it. There aren't a lot of contraindications with the CGRPs. Having said that, everyone is unique, everyone is individual. And if there's a significant risk, it might even depend on the severity of the osteoporosis within an individual. So it really is something that you probably need to speak to your doctor about. I'm sorry, I can't give you a clear answer on that. Moving now to other medications and alternative treatments. I can see there's a couple of questions here in this area. So Julie and Russell had a question about saying that some people use hydrolyte on a regular basis with great success. Can you use this on a continuing daily basis? That's a great question. You can have hydrolyte several times a week, I'm sure, without issues. Now, this may depend on individuals. Again, there may be some people that react in a rare way to some of the ingredients in hydrolyte. But personally, I can say that I use hydrolyte fairly frequently, particularly when I'm traveling on planes. Hydrolyte for me has been one of those things where I can take it on a plane and I don't need to use the bathroom, but I can still maintain my hydration, and it can actually address a lot of the tension headaches that I tend to get nowadays on planes. And when I used to travel, I used to get migraines, but now it's tension headaches, and hydrolyte has been really helpful with that. I would read the back of pack on the hydrolyte pack. You could speak to your pharmacist if you're concerned about it, or even your healthcare professional. You could even call the Hydrolyte organization. I'm sure there's contact details there about having it every day. But water is a good option as well. You don't need to have hydrolyte every day. Water is a good option if you're sort of worried about dehydration and those factors. But it is certainly a tool that I have in my toolkit. And it's also something I use for my young child when they have a fever. I give them an hydrolyte ice block. I find that really helpful with a fever, not necessarily connected with migraine, but you can imagine if you have a child that has nausea with migraine, having an ice block might be helpful, might be easier for them to stomach as well. Susie asked about the general length of time needed to trial each type of medication if it's going to be beneficial, so the triptans and CGRPs. So I mentioned earlier that CGRPs, usually you need a couple of months, you need a couple of doses for it to reach its full effect. That's true with Botox as well. With the triptans is a little bit different. It's more about giving it a couple of treatment options with migraine attacks. But if you're treating a migraine attack with a triptan, but every time you get to the triptan, it's always, the migraine attack has already been established and it's been entrenched for a while, you're not really giving the triptan a fair chance to succeed. What we need to be able to do is treat migraine attacks early. And so that's really a consideration, is the timing of the treatment. But certainly if you've given it 2 to 3 goes, you've taken the treatment early, then it may, and it hasn't had an effect for you, then it may be an indication that you need to try another triptan, for example, or a combination, depending on how many other triptans that you've tried. So great question there from Susie. Biofeedback devices is a question that was asked by Todd, what's being used? And we also had a question from Catherine about if we can talk about any recommended biofeedback treatment options and particular devices available in Australia. This is a tricky one because it was asked to Dr. Bronwyn Jenkins, and she couldn't recommend a clinic or location that treated migraine specifically for biofeedback. But what biofeedback does, I've been to a physical therapist that was also active with biofeedback, and it basically uses devices that you get hooked up to that look at, for example, like you could put something on your finger, and then you can sort of be trained on how to get more blood flow to your finger. And so we know that during the body that we react to certain things that happen during a migraine attack, and if we know, if we learn to recognize some of the early signs of a migraine attack through biofeedback, through changes in our body. For example, a lot of people go pale with a migraine attack, right? So does that suggest that blood is draining from the brain? Do we get cold fingers or extremities? Do we have numbness or tingling in our lips or nose or other extremities as well? These are all signs of a migraine attack. If we are able to identify certain things that are unique to us and intervene through biofeedback, through learning how to sort of either redirect blood flow or address some of those things, that's kind of what biofeedback taps into. So those devices are typically used in training. So you'll have several sessions of biofeedback. They're not sort of devices that you take home and use every time necessarily. And the Australian and New Zealand Headache Society at this stage don't have recommended clinics to approach. So you might have to do your own research and see for yourself at this stage. But they have been found to be useful, particularly in children who can develop the skill a lot quicker than us generally, because they're young and very receptive to this type of thing. But they are still helpful in adults as well, it's been shown. Same with cognitive behavioral therapy. Then we've got another question here from Glennis, who asked if I believe that if you experience migraine headache, you're increased risk of stroke. What about triptans? Do they further increase the risk of stroke? So we did have one of our experts speak about migraine and stroke. If you have a certain type of migraine, then there is an elevated risk. Now, what is that elevated risk? At the moment, the risk of stroke in the general population is quite small. If you have migraine with aura, so the type that has a visual disturbance or another type of aura, such as that has been described, that there are different types of aura that can be sensory and affect your ability to speak or to function. If you have migraine with aura, there is a slightly elevated risk. Now, what that does is it adds a small risk in the general population with a small risk with migraine with aura, and you have a slightly elevated risk. Is that risk still high and worth worrying about? No. If you have migraine with aura, can you still take triptans? Yes. If you have a history of heart disease in your family, so if you have a parent or a relative that has had a stroke, and particularly if you're advancing in age, if you're considered a senior, if you're over the age of 60 or 65, then it's worth having a conversation about, if you have migraine with aura, you now have some risk factors in your family. If you've been taking a triptan, it's worth speaking to your doctor about it. You may be advised to switch over. But for the general average person with migraine, who don't have migraine with aura but just have migraine without aura, triptans are generally safe. Now, again, this is where we need to speak to our doctor, because I don't know your personal medical history, and without knowing that, it's not. I'm not able to. Even if I was a doctor, I wouldn't be able to recommend that or confirm that triptans are safe without assessing your full history and looking at what other factors may be playing a role. But generally speaking, yeah, it's fine to take. Mark had a question about a new poll for those with 1 to 5 days to see a breakdown as to the. Sorry, Mark, if you can clarify that question for us, I will happily answer it, but I'm not following what the question was just there. There was another question about magnesium from Narelle. What do you think about magnesium? So magnesium is, for me, and this is very personal, but I've tried a bunch of different treatments for a bunch of different supplements, I should say, over the years for migraine. And out of all of those treatments, for me, what I did was I took a whole bunch. I spent a fortune paying for these treatments, high quality treatments, because a lot of supplements, it's easy to get a lot of junk and have low quality. And of all of the supplements I've tried, I peeled back one at a time what those supplements were that I was taking. So I tried magnesium, I tried coenzyme Q10, I tried riboflavin, I took a bunch of other stuff, but those three are the three that probably have the best evidence for migraine. Magnesium is the only supplement I still take today, every day, which is interesting. Now, that's an individual one for me. I think magnesium has been helpful with my migraine condition, but I take a specific type of magnesium that makes it more bioavailable. And so I take a form of magnesium called chelated magnesium, which is spelled CHELAT ED. Chelated magnesium, for example, is magnesium glycinate, and I take between 200 and 400 milligrams of that per day. Magnesium is a tricky it's a tricky one to measure. Apparently 50% of people 50% of women are magnesium deficient, which is very interesting. And it's hard to measure if you're deficient in migraine without doing quite a difficult sort of test. It's not easy to get that test done. So perhaps one of the best ways is to get a high quality magnesium supplement and start taking it on a daily basis and seeing what kind of results you get within sort of 3 months. One of the common side effects of magnesium, particularly lower quality magnesium, is diarrhea or sort of gastro symptoms. And that's often a sign that you're taking too much magnesium. So you can adjust your dose, but it's also a sign of a lower sort of quality of magnesium. It's a gray area. I would say, if you can, speak to your doctor about it, or speak to a nutritionist as well that can make recommendations for you. Not all brands are equal, and sometimes you pay for what you get. So sometimes the cheapest options are not the best, and supplements are a very unregulated space by and large. So I hope that helps. So Simone had a question about if there are any treatments that are on the PBS. She was on Maxwell but had to stop due to the cost. That's a great question. I believe there are. I haven't checked that in a while, but certainly there are treatments. I know Imitrex, which is sumatriptan, is available depending on the format. Some formats are more expensive. I know the injection is very expensive. It may be something like 20 to 40 to to $60 a dose. Don't quote me on that, but it can be very expensive. But that was one of those treatments I mentioned earlier that was used sometimes in cluster headache. And it's a sort of an auto injector. But there are other forms of sumatriptan that you can take that are not nearly as expensive. They may be $10 a dose or something equivalent. So yes, there are other triptans that are sort of more affordable. Vicky asked, how can I get a triptan? Triptans are available through a prescription. So you'll need to go to the doctor to get it. I believe there may be a way now to get triptans at lower doses and lower quantities without a prescription. You can go and speak to your pharmacist about that. It's free to go and have a chat to the pharmacist. You just go into the store and you can ask them that question. I'm not sure if that's been passed. I know that there was some activity in Australia specifically about making lower doses of triptans available over the counter. So something to have a chat about. In terms of advocacy, there's a question here from Tanya. And she asked a question about, are we advocating for studies to be done here in Australia? And are we also getting the GPANs into Australia through the TGA? She said that all drugs take a very long time to get here, even if they're available in the States for quite a while. Thank you for your hard work. Thank you for the question, Tanya, and for the feedback. We do support headache research through the Brain Foundation and Migraine and Headache Australia. We try to fund a research project every year. We have an independent scientific panel that evaluates submissions for research into headache or migraine. And so if we get a great submission coming through for migraine and headache, then that basically goes to the scientific panel. I'm not part of that scientific panel, so I don't have a say in that, which is probably a good thing. So there's no conflict of interest. And so that's kind of the process for submitting that. But it just depends what comes through. Sometimes we don't get many submissions at all for migraine or headache, and so we're limited into sort of what we do research into. But we love to support that, and certainly New Delhi persistent headache is an area that needs more research. I spoke a little bit earlier about the GPANs arriving in Australia. I think they will be arriving in Australia. They'll be coming. They will be arriving. They're fantastic and exciting new treatment options that could help revolutionize some of the treatments. So I'd be surprised if we don't see them within the next 12 months to 3 years. But it does take time. We can do only so much regarding those treatments arriving here in Australia, but we are working with organizations to the extent that we can to encourage them to bring those treatments out promptly, especially after the success of these treatments that we see overseas. Talking about lifestyle and trigger management, there's a couple of questions here from Karen, Suzanne, and Susie, so I'll answer some of these. So so Karen asked that she struggles to think or look at the phone when she has a migraine, and it's affected her in the migraine app. So that may make her feel worse. That's true. I think that if you have a migraine attack, you just want to sort of take time out, just relax, let the brain recover, and most people will go to a dark, quiet room. Sleep is very effective. Sleep is a great treatment for migraine. And we know sleep is also involved in triggering migraine attack when we don't get enough of it. Sometimes oversleeping can be a trigger for people with migraine, but for me personally, I've found sleep to be one of the most effective treatments. I don't sleep just by itself. I also take treatments myself, but sleep is very helpful for migraine. So yes, I would definitely support that. Suzanne said that apparently there's a lot of foods that tend to give a headache or migraine attacks. What I would say with food triggers is that there are a lot of potential triggers. There's almost any type of food or drink, alcoholic drink, can be a trigger for one person or another. I don't think there's someone who's triggered by everything, but it's very individual and very unique. And what I also notice is that there are certain foods that I can have that are triggers for migraine. But if I'm managing all my other triggers, if I'm managing my sleep and and my diet in general, or my stress levels, or my movement and exercise, if I'm not sitting at a desk all day and I'm not tired, then I can indulge a little bit with foods that may be triggers for me. But this is something I'd only do once you're episodic. If you're chronic, then and this was true from my own experience. When I was chronic, I was doing absolutely everything I could to address my migraines and reduce them, and that included taking preventative medication. It included devices. It included supplements. It included keeping a diary and doing all those lifestyle and behavioral things. Then once I got into episodic migraine, I was able to sort of relax things down a little bit, and that took a fair bit of time. I struggled with chronic migraine for 7 years. I wasn't super disciplined over those 7 years because I didn't know what I didn't know. But certainly towards the end, I started to improve my understanding and knowledge. And if you're here today listening to this webinar and listening to some of the other webinars, you're on the right track as well in terms of understanding your migraine and being able to take greater control over what you can control. So I wouldn't worry about every single food that may be a trigger, and you can be quite dynamic in it. If you're feeling good, then and you're episodic, then you can experiment if you're feeling comfortable, but be prepared if it does trigger a migraine attack, to have your treatment nearby. One other little hack that I'll share with you that someone shared with me a while ago, which I actually have found to be true myself. I can't promise that it'll be true for you, but if I have a trigger food, say for example, it's chocolate. If I have a trigger food like chocolate and I really want to have some chocolate, maybe it's chocolate cake. What I've found is if I have healthy foods prior, like, if my main course is a healthy food that doesn't have any triggers, and I've got something afterwards that I can eat that it's also healthy and not a trigger, and I have a little bit of chocolate cake in between, then I'm actually fine with chocolate. Like, I can actually have the chocolate cake. For some reason, if I have something before and afterwards that's safe, it makes having that trigger food in the middle much more, much less problematic. So again, I would only suggest that if you're episodic. If you're chronic, I would probably try to avoid those until you can really sort of get a grip on get your migraines under control a bit more. But something for those who are episodic amongst us, and also hope for those who, once they are chronic, once they remit from chronic migraine, that there is hope that you can enjoy those foods that may be a little bit naughty, but would still like to have. After all, life is for living. Like, no one's perfect. I'm not perfect. I still drink alcohol at weddings and special events, and I'm able to do so without getting a migraine. But I make sure that I'm taking care of the other aspects that affect my migraine conditions when I'm doing that. Suzanne asked about low tyramine diets. Do I believe in these? I've tried doing a low tyramine diet in the past. It didn't work for me. But I know that there are other people who have tried it and found success. I think when you eliminate things like tyramine, when you eliminate MSG, these are all things that are found in a lot of processed foods. So actually, just by eliminating more processed foods, you're eliminating a lot of these other triggers that are known to be problematic in migraine. So that's why I think the easiest way to think about it is just by minimizing the processed foods that you have, and trying to eat healthy majority of the time. You don't have to do it all the time, but just try and, maybe it's just starting with one less processed meal a week. If you have an indulgent takeaway meal that you order on Uber Eats or something equivalent, and you do that sort of 3 or 4 times a week, maybe it's just reducing that to 2 times a week, or just to the weekends, when you're perhaps more resilient because you're less stressed with work during the week and you're able to sleep in and so forth. So it's really just being dynamic in that way. I know there's a lot more questions that have been coming through. I'm conscious of the time as well, so I would like to thank you. I'm sorry I wasn't able to address everything, but if you still have questions, the support group is a great place to connect with other people like yourself, where you can exchange tips and stories from other patients. I would encourage you, if you haven't been to the doctor in recent years, to go see your doctor, because the treatments today with the CGRPs and other treatments and options that are available, they're so much better than where they were only a few years ago. and you might find that your doctor knows a whole lot more about migraine. And certainly if you've been seeing a neurologist or have seen a neurologist in the past, neurologists know a lot more about migraine as well. And if you can see a headache specialist, that's even better. And I would encourage you, if you have significant issues, if you have refractory migraine, if you have cluster headache, to get a referral to see a doctor, to see a headache specialist, I should say, because you want to make sure that you're getting that good care, because your quality of life is worth it. You are worth fighting for. There are options available, and for the vast majority of people, not promising it for everyone, but for the vast majority of people, we can reduce the burden of migraine. You can get a good quality of life. So I hope that you are feeling hopeful. I hope that we've answered a couple of questions. I really appreciate all of your support and attendance, and I'm glad that we got this chance to catch up. For now, take it easy. Enjoy the rest of the week and the weekend, and we'll be in touch next week. We'd love to hear from you about what you thought about the event, and we'll be sharing the recordings for those that maybe have missed some of those earlier sessions. But for now, thank you so much, everyone. It's been great. I've really enjoyed this week. I hope you found it helpful, and we'll be in touch again very shortly. Bye-bye for now.